Vitiligo. Definition. Vitiligo is an acquired, autoimmune condition in which functional melanocytes disappear from affected skin. The cause is unknown. Lesions clinically appear as totally white, non-scaling, sharply demarcated macules. Vitiligo, depigmented macules in common periorificial distribution. Incidence. The reported incidence of vitiligo varies with the population studied, but it is thought that about 1 in 100 people are affected worldwide. In the past, higher incidence rates were thought to occur in dark-skinned individuals, but actually this reflected the observation that vitiligo is more noticeable in more darkly pigmented skin. It is now known to occur equally across all ethnicities, genders, and ages. The peak incidence is in the 10 to 30-year age group. In the United States, vitiligo is estimated to occur in around 1% of the general population. History. Vitiligo is usually asymptomatic. It begins as one or more small spots that gradually enlarge. The affected areas sunburn easily. Most patients seek medical help because of cosmetic and cultural concerns. Physical examination. The primary lesion is a white macule that is usually totally depigmented. This feature can be appreciated best by Wood's light examination, which accentuates the pigment contrast and may also make evident previously undetected areas in lightly pigmented skin. The skin otherwise is normal, specifically, no scale is present. Macules of vitiligo are round or oval. They may become confluent as they enlarge, resulting in a large macule that has an irregular border but remains sharply demarcated from the surrounding normal skin. Vitiligo can affect any area of the skin and mucous membranes, but the most common areas are the extensor bony surfaces, backs of the hands, elbows, and knees. And the periorificial areas, around the mouth, eyes, rectum, and genitalia. Involvement of hairy areas often results in depigmentation of the hair. Vitiligo often presents in a symmetric distribution, underscoring the autoimmune nature of the condition. Vitiligo, hair turns white with follicular involvement. Vitiligo, depigmented macules in acral distribution are difficult to treat. Differential diagnosis. Vitiligo is more often overdiagnosed than underdiagnosed. Tinea versicolor, pityriasis alba, and post-inflammatory hypopigmentation are among the most common differential diagnoses of vitiligo. However, vitiligo is the only one of the common white spot diseases that results in total depigmentation. In addition, it can be differentiated clinically from tinea versicolor and pityriasis alba by the absence of scale. Finally, vitiligo lies flush with the skin, so note the absence of elevation to also aid in differentiation. Laboratory and biopsy. The laboratory is not helpful for diagnosing vitiligo. Serum thyroid tests, blood glucose or hemoglobin A1c, and a complete blood count with differential may be ordered to screen for occasionally associated thyroid disease, diabetes, and the rarely associated pernicious anemia. Biopsy is not usually necessary. If performed, it will show an absence of melanocytes, sometimes with accompanying inflammation. The presence or absence of melanocytes may be difficult to appreciate with routine hematoxylin and eosin staining. Special stains and techniques are required for definitive identification. Clinicians can consider taking a biopsy with a portion of normal skin included to evaluate for the absence and presence of melanocytes in affected and unaffected skin, respectively. Clinical and histopathological vitiligo. A. B. Vitiligo involving the distal lower extremities, A, and dorsal hand, B. In patient 1. C. Biopsy of a depigmented macule showing complete loss of basal layer melanin. D. Mart 1 stain demonstrated complete absence of epidermal melanocytes when compared to appropriate reactive controls. Therapy. There is no cure for vitiligo. Emotional support is a top priority. The goal of therapy is to manage the cosmetic disfigurement caused by the disease. Therapy for repigmentation is prolonged, and the results are often suboptimal. For limited disease, the topical Janus kinase inhibitor, Ruxolitinib 1.5% cream, is the first treatment approved by the U.S. Food and Drug Administration, FDA, for repigmentation in patients aged 12 years and older and is applied twice daily. Topical high-potency steroids, example, clobetasol, have been successful in some patients. To avoid skin atrophy, use the treatment at intervals, e.g., alternating twice daily for 1 week and then 1 week off. Topical macrolides, Protopic or Elidel, are popular for use in facial and genital vitiligo. These agents do not cause skin atrophy. Small studies have demonstrated efficacy using mometasone steroid topically with bimatoprost 0.03%, Latisse, daily for 12 weeks. Facial and truncal vitiligo respond more favorably to medical therapy than vitiligo located on the extremities. For rapidly progressing vitiligo, a short course of systemic corticosteroids can be considered. However, dosing guidelines and length of treatment have not been delineated, and this treatment should be used thoughtfully, weighing the risks and benefits. For extensive involvement, the administration of UV light is recommended. The current treatment of choice is narrowband UVB, which can be used in adults, children, and pregnant patients. The Excimer laser, which emits light at 308 nanometers, close to narrowband UVB wavelength, is another form of phototherapy with the added advantage of delivering laser light to affected skin only, usually done twice weekly for up to 6 months. Long-term effects are unknown. Another phototherapy, which is more difficult for the patient and reserved for the most severe and recalcitrant cases, is the administration of a psoralen medication, trimethylpsoralen or 8-methoxypsoralen, followed by exposure to long-wave ultraviolet A light, PUVA. The psoralens can be administered topically or systemically, more frequently the latter, especially for widespread disease. Some 100 or more treatments are often required to achieve the end result, which in some patients is complete repigmentation, in others only partial pigmentation occurs, and in the remainder, treatment fails. Surgical therapies have also been employed occasionally. Normally pigmented skin is harvested, by suction blisters or punch biopsies, and transplanted into vitiliginous areas. Experimental transplantation of cultured melanocytes has also been reported. An alternative is to cover the lesions with a cosmetic that is blended to match the color of the patient's normal skin. The products most frequently used for this are Covermark and Dermablend. In selected patients with extensive disease, the best cosmetic result may be obtained by depigmenting the remaining normal skin. Topical application of 20% monobenzyl ether of hydroquinone, Benican, is used for this, but the patient must be aware that the resulting depigmentation is irreversible and treatment can take up to a year. This option is FDA approved for depigmentation. Therapy for vitiligo. Initial. Emotional support and covering cosmetics. Covermark. Dermablend. Topicals. Ruxolitinib 1.5% cream applied twice daily. Clobetasol cream twice daily alternating 1 week on, off. Topical macrolides twice daily, especially facial and genital vitiligo. Narrowband UVB or 308 nanometers Excimer laser. Alternative. PUVA, topical or systemic. Surgical, epidermal grafting or autologous mini-grafting. Depigmentation of normal skin in recalcitrant, widespread disease. Course and complications. The course of vitiligo is unpredictable. In most patients, it is chronic and often slowly progressive but can be rapid in others. Occasionally, it involves the total body surface, resulting in complete depigmentation. Spontaneous repigmentation occurs in a minority of patients but is usually incomplete. Repigmentation begins around the hair follicles, so it appears as freckles that become confluent as they enlarge. Approximately 40% of patients will relapse within the first year after successful repigmentation. Associated systemic disorders occur in some patients with vitiligo. Thyroid abnormalities, including Graves' disease and thyroiditis, are the most common, with a frequency ranging from 1% to 30%, depending on the series. Addison disease, pernicious anemia, diabetes mellitus, and alopecia areata are other autoimmune disorders uncommonly found in association with vitiligo. Experiments indicate polymorphisms located in the gene NALP1, which is involved in the regulation of innate immune responses, play a role in these other disease susceptibilities in a subset of patients with vitiligo. Many patients with vitiligo, particularly deeply pigmented patients, may experience social stigmatization. In some cultures, vitiligo has been confused with the white spots of leprosy and has resulted in social ostracism. Advocates, social media movements, and the arts have made efforts to destigmatize vitiligo in recent years. Whether or not to manage and treat this condition ultimately lies with the patient. Pathogenesis. Melanocytes are absent in vitiligo. The mechanism for their disappearance is not known, but multiple theories exist. For proposed theories, not necessarily mutually exclusive, are highlighted. 1. Autoimmune. Investigators have proposed that melanocytes are destroyed by an immune mechanism. Antibodies against melanocyte antigens have been detected in patients with vitiligo. These may be the primary cause of the disease, or they may occur secondary to an initial injury to the melanocytes that results in the production of antigens with subsequent antibody formation. Cellular immune mechanisms have also been implicated in melanocyte destruction, such as activated cytotoxic CD8 plus T lymphocytes and numerous cytokines. 2. Oxidative stress. This theory posits that oxidative stress promotes vitiligo by the activation of the innate immune response. It is thought that reactive oxygen species act as signals which activate pattern recognition receptors which then trigger inflammation leading to the recruitment of cells in the innate immune system such as macrophages and natural killer cells, with the end result being the destruction of melanocytes. 3. Neural. This theory proposes that a neurochemical mediator is responsible for the destruction of the melanocytes. Some animal models have clear-cut neural control mechanisms for pigment formation. 4. Self-destruction. The intermediate compounds in melanin synthesis are cytotoxic when present in sufficient concentrations. The self-destruction theory holds that, in vitiligo, these compounds accumulate in melanocytes and eventually destroy them.
Clinical case. A 19-year-old woman presents with progressive, asymptomatic white patches on her face and both hands for the past 10 months. She first noticed a small depigmented patch around her mouth, which gradually enlarged and was followed by similar lesions on the dorsal hands. She denies itching, pain, or scaling. There is no history of preceding rash, trauma, or topical medication use. Her mother has a history of autoimmune thyroid disease. On physical examination, there are well-defined, chalk-white macules and patches on the perioral region, dorsal hands, and fingertips. The lesions are completely depigmented, symmetrical, and non-scaly. Some hairs within the lesions are white, leukotrichia. Sensation is normal. Examination under a Woods lamp demonstrates bright blue-white accentuation of the lesions. What is the most likely diagnosis? A. Vitiligo. B. Tinea versicolor. C. Pityriasis alba. D. Post-inflammatory hypopigmentation. E. Nevus depigmentosis. Correct answer, A. Vitiligo. Explanation. Vitiligo is an acquired autoimmune disorder characterized by well-demarcated depigmented macules and patches resulting from the destruction of melanocytes. Typical features include chalk-white, completely depigmented, lesions. Symmetrical distribution. Common involvement of the face, hands, and acral areas. Absence of scaling. Bright blue-white fluorescence under Woods lamp. Leukotrichia may be present. Frequently associated with autoimmune diseases, especially autoimmune thyroid disease. Why the other options are incorrect. B. Tinea versicolor. Usually presents with hypopigmented, hyperpigmented, or erythematous scaly macules on the trunk, neck, and upper arms. Fine scaling is evident on scratching, evoked scale sign. Woods lamp may show yellow gold or copper orange fluorescence. KOH examination demonstrates the characteristic spaghetti and meatballs appearance. See pityriasis alba. Common in children and adolescents. Ill-defined hypopigmented patches with fine scaling, mainly on the cheeks. Pigment is reduced, not absent. Wood's lamp does not show the striking accentuation seen in vitiligo. D. Post-inflammatory hypopigmentation. Occurs after eczema, psoriasis, burns, trauma, or other inflammatory dermatoses. There is usually a clear history of preceding skin inflammation. Lesions are often poorly defined and gradually repigment over time. E. Nevus depigmentosis. Congenital or appears during infancy. Stable in size relative to body growth. Does not progress or develop new lesions. Usually unilateral and not associated with autoimmune disease. Key learning point. The combination of well-defined chalk-white depigmented patches, absence of scale, symmetrical distribution, leukotrichia, positive Wood's lamp findings, and a personal or family history of autoimmune disease strongly favors vitiligo over other causes of hypopigmented skin lesions.